recording. Great. Great. We'll just give folks a couple more moments before we go
Oh,
ahead and get started.
our socially determined friends are here. Lauren, I noticed
Good.
I have a little call you in moment, and I didn't even know you were going to be here. How good is that? All right.
All right. Have a couple people in the waiting room and I'll let them in. I see it's like one after on my end. So I think we can go ahead and get started as people continue coming in. So thank you all so much for joining. This is our May Affinity Group meeting. Last time we met was in March. I feel like that was 100 years ago. But so glad that you all were able to join, and hopefully you've all been enjoying some nice spring turning into summer weather. I'm really glad that you're going to be joining us today. We have a great discussion and conversation that'll be spearheaded by my co-presenter here, Chris Durance, and more on that. But we will also have a conversation with Sarah DeSilvia and Corey Smith, who are Gravity Leadership. I'm sure that you're all familiar with them. So we'll go ahead and get started. Just wanted to kick off with some antitrust practices like we do at the beginning of each Gravity meeting. So just participants have the responsibility to comply fully with federal and state antitrust laws. Individuals speaking or providing written communication shall refrain from any discussion. I won't read through every bullet here, but familiarize yourself with those and make sure that you are adhering to them. And just a few housekeeping reminders. Again, thanks so much for joining us this afternoon, or I guess morning if you're on Pacific time. This meeting is being recorded and it will be available on the Affinity Group Confluence page following the meeting. Please mute yourself when you're not actively speaking just to eliminate any background noise that we have. And feel free to use the raise hand function and chime in. If you have any questions along the way, we definitely want this to be a dynamic conversation. So do not feel like you are interrupting. Please feel free to chime in at any moment and use the chat. Feel free to also mention where you're from and what organization you're with, just so we know who's in our virtual room here. Okay, so here's our agenda today. So, like I mentioned, Chris Durance, my co-presenter with CVS Health, will be leading a presentation. Sarah and Corey will also be giving some gravity updates, and then the last 20 minutes or so will be reviewing some use cases. So, Chris will be able to introduce himself in just a moment, but I think you can see him on camera here. So, we're very excited to have him. And that will be our agenda for today. So, just a quick gravity overview. If this is like your first meeting joining us, very excited. If this is your first call, please let us know in the chat. But we are a collaborative with the goal of developing consensus-driven data standards to support the collection, use, and exchange of data used to address SDOH. So, I'm very excited that you all are here with us today. And again, if this is your first meeting, please let us know in the chat. That will be very exciting. And 2026 project sponsors, members, and partners. Just wanted to give a big thank you to all of the organizations that you see on the screen here. We have our premier, partner, associate, and designated member partners. So big thank you to all of them. The Gravity Project would not be possible without their partnership with us. So thank you so much again. Okay, Sarah and Corey, I believe there are some Gravity announcements to go through before we really get started.
Yes, and I think Corey, do you want to lead the
Yep,
first?
sure
Because I
thing.
think there's an update hot off the presses, right?
Uh,
Corey, go.
yes. So, hello everyone. Yeah, just uh, you can always join us on our public calls every other Wednesday, 1 to 2 p.m. We are focusing on our ballot reconciliation. However, our standard for trial use version 3. However, I think our meeting yesterday we made it through all of our tickets, or almost all of our tickets. So we are well into um, uh, convening the public and giving visibility into the work, and we're now transitioning to implementing that work in the IG. So big stuff there, and thank you all for those who participate.
Thank you.
Hopefully, Sarah, that was the big.
That
Hopefully,
was
that was
my
the hot
hot
off.
off the
Okay,
presses.
all
It's not
right.
almost done. It's
Yeah.
sorry. So terminology, we have our consensus vote today. So that's a big day for Gravity. Today at 4 o'clock, we have our final terminology public meeting of our spring 2026 cycle. The vote for our domains of child maltreatment, mistreatment of non-elder vulnerable adults, and legal needs. After this meeting, we tend to go quiet as we focus on just trying to enact all of the consensus findings that we have in our public work together. And then we're focused on planning for our fall 2026 domains when we kickstart just at the beginning of August, focusing on physical disability, communication access, and access to primary care. Please send us subject matter expert ideas if you have them. We're incredibly grateful for all of you and your efforts. And then, Demery, do you want to do the last one? It's you.
Yeah, so just highlighting that our next meeting for this group will be July 30th, 2 to 3 Eastern, and it will be focused on community health workers diagnosing and documenting social risk findings using the national core national instruments. So we hope that you join us again when we reconvene in July. Okay, and then I just wanted to quickly give a shout out to the 2026 Civitas Annual Conference. So again, my name is Demery Henderson with Civitas Networks for Health. I'm a grants and programs manager there. That's my day job. Um, so we're really happy to be Gravity partners and members. So I serve on the operating committee. Jess Little, who is Civitas's chief operating and programs officer, sits on the steering committee. So we have a really great relationship with the Gravity Project. And we hope that you all can join us in Arlington, Virginia, just right across the river from DC in the Crystal City neighborhood, if you're familiar with the area, for our 2026 annual conference. So we have information about discounted hotel and flight options this year, which is very exciting. Discounted flights will be with United and Delta. So if you're going to be taking either of those, be sure to check out the website for discounts. Um, but yeah, feel free to join us. We would love to have you. Our agenda will be being posted at the end of this week, which is very exciting. And then registration will be opening shortly. So just giving a plug there again. And if your organization is interested in sponsoring, there's information about that as well. But there's going to be quite a few Gravity sessions and Gravity members that'll be there. So we would really love to see you all there. It'll be a great convening. And I know Sarah has a few sessions. Our friends at New York will have a few sessions. I know Find Help is sponsoring a session. So there will be great people and lots of members and familiar faces. So we hope to see you all there. Okay, now I will hand it over to Chris Durant over at CVS Health. Correct me if I'm wrong, Chris. This might be your first meeting with us, officially as like a member co-lead of this work stream. So
It is.
we're so excited to have him.
Yeah, thank you guys so much. Yeah, so it's my first time. I just wanted to briefly introduce myself and then essentially just kind of share with you guys a little bit about like how we got to where we are in this conversation today. So because I'm new to the group, we did some pre-planning conversations before this meeting. And I think there were just a lot of conversations that came up from that we felt like, maybe this is a good time to sort of ground ourselves in as we're kind of getting started with this work group, just kind of having some honest conversation about where some of our challenges are with this work. And rather than, Sarah and Corey kind of talked about like, they're so busy in the weeds of actually trying to implement all of this work that sometimes maybe stepping back a little bit could be helpful for everybody. So I'm going to help us kind of hopefully do that a little bit today. But the intention of us doing that is we would love to have kind of an open conversation with you guys. I don't really just want to talk at you. Would really love to kind of hear feedback from you guys on whether that's just in the chat or whether you want to come off mute and kind of say, yes, this is something that we're struggling with as well. Yeah, so just a little bit about me. I'm with CVS Health. We were formerly the Office of Health Equity. That's kind of part of the conversation today, is sort of just the changes that are happening, I think, across the country and certainly within some of our organizations around terminology and how we talk about the work that we're all trying to get accomplished. And so we were formerly the Office of Health Equity. I'm now under what's called our Health Engagement and Access team. So really, it's still just looking at how do we best ensure that the folks that we're serving are being able to engage appropriately with healthcare and also access that healthcare, right? So whether we're talking about people with SDOH gaps, clinical gaps, health disparities in general, anything that sort of touches that work is what I help lead. And then I'll be working very closely with Demery and team on this implementation work group. So we could just go to the next slide, Demery. I think the first thing that just really came up in the conversation, which again, all of us here on this call know this, but it's really that we are all operating within this very fragmented ecosystem, right? And I think that ecosystem um, is even different for us depending on where we sit, right? What is it that our organization essentially is tasked with? We all sort of work within our own ecosystems, right? But then I think this larger ecosystem just across the nation, when we're talking about both health and social care, which is really where my work sits at the intersection of, right? So I may live within this payer provider ecosystem of healthcare. But I bring the lens of social care with everything that I do. And 15 years of my experience has really been mostly on the public and nonprofit side of this work. And I'm newer to the payer and provider side of this. And the reason that I came on board to do the work, and I know we've got some other folks here that are in the payer provider system as well. I actually started with Elevance, formerly Anthem, doing Medicaid 1115 waiver programs. And that really sat at this perfect intersection of my work, where formerly I had been leading local government care around health and human services. I then worked in a continuum of care for a regional continuum of care. And then I was also a TA provider for HUD across the nation and trying to really implement effective COCs. And there came this opportunity where it was like, wait a second, what's happening here? We've got Medicaid that's doing this housing work. How is this all coming together? And for Florida, it was the first time that they had done that work to sort of say, well, how can we make all of this come together? And it was this interesting experiment that I got to really be a part of spearheading with three other managed care organizations at the time to say, what does it mean to really try to address folks who are experiencing housing instability, who are also Medicaid recipients, and who at the time were either living with behavioral health care conditions. So they were either living with SMI or SUD or both in a lot of cases. And then also many of them were HIV positive as well, for the plan that I was working with. So these folks who had these massive barriers with just even entering the healthcare system, and then Medicaid being unable to actually pay for housing, how do you really get these providers to come together, right? Who are non traditional providers on the housing side with these behavioral health care providers? How do we share data? How do we build real partnership? How do we even speak the same language, right? We all kind of talk about this work differently. And that was sort of my entryway into the world that gravity has kind of been living amongst for a long time. And I think what I want to just say today is, I don't think we're a fragmented system because people have not been trying really hard. I think we all come to this work deeply caring about wanting to make a difference in the lives of people that have been underserved in our communities. But again, we're all funded differently. We all have different, quality outcomes that we're held to, different standards we're held to, different systems that we report through. And Gravity, I think, is this amazing opportunity that for once we can kind of all come together as partners if we can really build effective trust and relationship among one another, to say we might be competitors in certain spaces, but we're all trying to make the same impact, in the people that we serve. And how can we do that effectively? And so I think there's sort of three things that just stand out to me as critical things to call out, which is we know what the research says. And I think a lot of those that are on this call, I don't have to sell this to you all. I think you all understand this. I think what's a challenge is how we sell it to our leaders, how we sell it to our policymakers, particularly in the climate that we're working in right now, where there's a lot of pushback against this terminology around things like health equity. And I think what we need to just, I hope that we can keep in mind and stay focused on is that no matter what we call this work, the reality is still the same, right? People are unhoused, and that affects their health outcomes. People are living in, underserved communities, and that affects their health outcomes as well. And I'm, of course, coming from a health outcomes perspective on this. Um, but we know that these issues are real no matter what we call them. And so, how do we make sure that we continue the work? And I think gravity is a great place to do that, right? How do we make sure we continue this work regardless of what policies change, regardless of what administrations come and go, because the needs are still going to be there for us to have to address. And so, if we want to just kind of go to the next slide, I want to call out one more thing, and then I'm curious if anybody just has feedback for now from anything that I've just said already. But I think we all are used to hearing AI now. I think we've been kind of inundated with it in the last year, just everywhere we turn. I feel like social media, but also within our organizations. I know from a corporate perspective, AI is getting pushed on us every single day, whether we want it or not. And I think that one of the important things to call out is that one, this is coming, right? It's here in a lot of ways. But it's our lives are going to be changing, and a lot of us don't know what that means yet. And that can be a really scary thing for us, I think, just as people. But then as professionals, especially as we talk about data, it's like, what is this going to look like? And not having those answers completely yet. And I think the most important argument that I would make is that if we don't figure out how to come together as partners in this kind of work, where we're all moving toward the same goal of trying to address the same social determinants of health problems, right? And we might be addressing those needs in different ways across our organizations. But if we don't figure out how to do this together through something like the Gravity Project, we are just going to see harm magnified in these underserved populations by AI, right? Like the data inputs um, are deeply affecting what those outputs are going to be. And as we continue to see these systems relying more and more on agentic AI and all of this sort of stuff, we really have to make sure that from an advocacy perspective, and also I think from a partnership perspective, and from a shared language and standards perspective, that those of us that are sort of the experts in this work, like we've got grounding and we've got like a framework that we're planted sort of in how we're doing this work so that we can speak to these businesses, these organizations, these tech, uh, you know, uh, everybody's very flashy right now, right? With AI, it's like we're getting inundated with all these tech companies that are like, look at what we can do for you, and look at what we can do for you, and none of them are talking about these kind of issues. Now, I'm sure that there are some folks out there that will um, come up to the surface where maybe they are talking about these issues more, but I have not met those people yet. And so to me, I think it's just a critical thing that we as a team, come together and keep thinking about, especially in this AI climate, more so than ever before, why this data matters to get it right. And to always be sort of optimizing how we're capturing this data. So um, I just want to pause there and just see if anybody has like any feedback. Jonathan, I see your hand raised. Yeah, go ahead.
Thank you for sharing that feedback, and I agree with you
Oh,
wholeheartedly.
Jonathan, it's a little hard to hear you.
Oh God, I can't believe it's 5 years into this, and I still can't figure out how to work my volume. Hold on a second. Um, so I think that to your point, like it's building a use case for why people need to be more proactive about these things, right? Because we know that an ounce of prevention is better than a pound of cure. And so trying to fix problems after they've already occurred is much, much more expensive from a cost benefit analysis than actually being proactive about these things. And I think that if you can actually get some of the companies that are like buying into the concept of how they want to use emerging technology to help solve problems, putting the impetus on them to think about how to make these things more efficient and understanding that that's the only way that they're actually going to be able to monetize those solutions, while also helping them understand that by quantifying the terminology and the taxonomy that Sarah and her teams were building around capturing social determinants of health can actually help quantify the cost of care. So when we go to policy development makers and we talk to them about what it is that we need to do from a reimbursement standpoint, from a coverage standpoint, realizing that those are taxpayer dollars that are being leveraged, and if everybody gets exposed to a potential crisis like in a public health emergency, It makes it easier to triage that data to make sure that you're getting the appropriate care to the people that need it most. So specifically, when you think about the teachers that were displaced and people wanted them to go back to school because they wanted to go back to work, that's great as long as you can make sure the teachers can go back to a healthy environment, and we're ensuring that we're not putting them at existential risk because we're subjecting them to potential public health emergencies that might be catastrophic. And so I think that if we can preface some of these things as being preventative and putting the cart before the horse to make sure that the resources are available before we actually need them, given a long enough time frame, it will actually reduce the cost of care, which every single taxpayer in the United States of America would care about, because it's actually relieving their tax burden while it's actually improving the quality of their commercial, economic, and social drivers of health and wellness.
Agreed, agreed, agreed. Yes, and I think that that's, I mean, that's part of what our conversation sort of originated with before we came to this meeting today, was like me talking more from a perspective of being within the payer side of this work. I see how, Jonathan, everything you just said, I see all of that, right? I understand how approaching these things the way we're trying to ultimately result, if we do this well, right, and if we train our workforce to understand how to interpret the intelligence and the data and how to use it effectively, it unquestionably um, is preventative in some ways and assists with reduction in cost of care and improvements in clinical outcomes. And like, we know the possibilities because we're bought into this. But I know, at least from my experience, I work in an organization. We have 300,000 people that work at CVS Health. It's just not possible to have the kind of reach that we can make everybody within an organization of that size really understand that SDOH is not an afterthought, right? Which is how the system has been designed. It's seen as this sideline issue, right? Just as much as health equity has been seen that way. Whereas we all understand and know, no, these are human beings. We are all affected by that. I mean, every single one of us on this call, we have social drivers of health that have affected our lives in different ways. We all experience challenges and different risks and all of these sort of things that we understand this. I think changing the conversation um, is the piece that I still struggle with, and I think that that's part of where there's some value in some of the implementation work group of this, is like, if we can hear from you all to say, yeah, we're actually struggling too, to get our leadership to understand, like, why is this important that we need to invest money into changing the way that our infrastructure is on the back end, right? Why do I need to make sure that my data folks are taking time out of their month when they've got all of these other projects? Why do they need to be on this what is this gravity project thing? I think the better we can tell that story of how it really, that business case and those use cases, that's at least been my experience of, it's a challenge to really get the right folks on those calls.
I don't disagree with that, but I think that some of us, and I'm going to try to keep the temperature down on this, right? But we're used to living in this fear-based mindset, right? Of, oh my God, the sky is falling and what's going to happen. And so when you have a whole generation of business leaders, and don't get me wrong, I'm not an ageist, right? I'm aging as I'm sitting here. But when you have a bunch of people that have never had the opportunity to address these issues in a certain way, and they were never talked about, getting them over the get it gap, over like having the conversations and being more proactive, is reducing the decision fatigue about all the administrative work that they've been doing up to this point. And so just asking the simple question of saying, had you been able to do what you do now more efficiently 20 years ago, what would you have done differently? How would you have done differently? And being able to build the tools and resources that allow us to capture that institutional knowledge and apply it more effectively and more efficiently is how we're actually going to add more value to the work that you've done historically and carrying it forward. And so then that way, from a sales aspect, it's giving them the idea and making them think that they came up with it. And that's the humility process of like understanding how to manage up, right? And I know I saw Lucy Johns, my old friend, on the call. She would always get upset with me because I'm talking about emerging technology. And I'm just like, listen, having been somebody who's worked in social care and done durable medical equipment in healthcare, if I didn't have to fax a 25-page document 5 times to 4 different providers and I could just click it, that would have made everybody's life a lot easier, including the patient. And being able to have that conversation in a very tongue in cheek but direct, proactive manner and creating the persistence in the market, because you're going to have to repeat it a number of times, is eventually going to be the so you mean to tell me that if my elderly mother gets sick with COVID or hantavirus or something, this means that she can actually get access to care more efficiently and more effectively, that'll actually reduce the ability that she's going to have an adverse event? Yes, that's exactly what we're saying. But we need to start with this. So again, an ounce of prevention is better than a pound of cure. But I'll get off my soapbox, right? Because this is why I stopped going to Sarah's meetings, because I'll get on my soapbox and hijack it.
We wanted people to get on a soapbox. That was the point of today, is just to kind of have open dialogue. So um, yes, agreed with everything. Just wanted to check in. Is there anybody else that wanted to add anything, had any questions, comments?
I see my friend Trish Salibi with her hand up,
Hey,
being
Trish,
amazing.
sorry.
Hi,
My,
it's like
my sister in social work and the good.
yeah, I never know how to describe myself in the chat because I wear many different hats, but I am a social worker, so I'm very much invested in social care, as you can imagine. And I think to Jonathan's point is, when I do a lot of workshops or webinars or grand rounds with doctors, everybody agrees, as you mentioned, Chris, we see the evidence, we know what social determinants or social drivers of health does in terms of health status and health outcomes, but it's that clinical burden, right? They're so inundated already with enough paperwork or let alone a 25-page fax. But they want it to be easier and built into the system. And I just came back from Geneva. So we had the first Connectathon. The report will come out between WHO and Fire. So Graham Grieve was there, and we worked through. We had Daniel Vreeman from Loink, and we had SNOMED there, and we were able to pull in working with ICD-11. So the push is going to be because ICD-11 can actually improve how we track social determinants of health. It when we created it, it was built in, right? Factors influencing health status or reasons for causing health services. It's in there. So I think that's also part of it is not perhaps having to sell to the provider end because it's in there. But then how do we incentivize it, right? But I think if we can better capture the data, code it uniformly, and we'll be able to pull in all the great work that Gravity and Sarah's team is doing through either direct codes or through post coordination with clustering. It's going to be amazing. It's going to really change how we look at it, right? To be able to say, okay, it isn't just about asthma as a diagnosis through ICD, but then we can link it to housing issues, right? Substandard housing and so forth in that post coordination cluster, and it to go into that system seamlessly. So I think I'm hoping as we build the infrastructure globally with these kind of partnerships that clinical providers will maybe be a little more or less hesitant, I said, to perhaps using it, and then the next step could be incentivize it. So that's my 2 cents. I'm optimistic after spending a couple of days in Geneva and seeing all the tech people work their magic that we can actually make this happen. Thanks.
Can I go ahead?
Chris, it's all, yep, it's all you.
Okay. So I'm particularly enthusiastic about a medium for communication as a supporting tool for these discussions, which is the fact sheet. The one-page fact sheet with and the backside a list of references, like peer-reviewed articles about the relevant points, and a fact sheet that's organized in a way that leads the reader to reach the conclusion themselves at the bottom of that page. They're like, oh, we need to do something about this right now. And so I'm wondering if, and I have been sort of in the periphery of this, work group for a while, just sort of, tracking along, to see if there's something that our community here in Eugene, Oregon can use. And I'm wondering if such fact sheets already exist, Or is that something that this group could, start drafting and collaborating on to get going? I've been drafting fact sheets using ChatGPT, and I'll just tell if I get the right content, I'll just tell ChatGPT to, generate me a fact sheet like that other one, but have it address this issue to this audience. So anyway, anybody want to work with me on that? Or is it already done and I just didn't know? And then please somebody put a link in the chat because I want to leverage that kind of content in my community and my state.
So yes, we want to work with you on that, Chris. I think so Sarah De Silva, I think we've informally met, right? So we this is exactly the type of question I think Chris and Demry wanted to give space for, so that we can figure out how to support implementation. I think I would love to not get to the slides that we have after this conversation and just keep on talking, but some of what we tried to think about, again, really driven by what happened is that Chris came into this space where we were so like implementation focused that he inspired us to get to pick our heads up again, right? And to think about why stories and to think about the cases that have yet to be made, right? And so some of the materials on the rest of these slides are all about stories and case making, and they're ripe for turning into a fact sheet, Chris. So I think if you can send us the idea for what the fact sheet you want, we can easily work together and wordsmith it as a collective to be something that can be valuable across like the nation, no question. And then maybe some of the content on the slides, which Chris is like story, evidence, data, like in every single, like maybe that will inspire some of that work to come. Chris, I don't know if you saw the slides afterwards, but I'm thinking it's kind of similar.
Yeah, well,
Yeah.
that's what I was going to ask. I mean, I feel like the next slide that I had, we kind of touched on already, of just like,
Mhm.
where some of the challenges sit right across our ecosystems, from a why perspective, right? Like, why is this challenging? Um, and I guess what I mean from why is, as I shared, um, it it has been surprisingly challenging for me to build, um, consensus and buy-in from some of my leadership around the Gravity Project. And I wasn't really prepared for that. I really thought this is such an obvious, critical project. What are we even talking about? And it really made me step back to have to remember, because this has always been my world. Social care has always been my world. That it's just not that way for some of our healthcare organizations, and that there is some, um, I've just learned a lot from, like, the as we as Trisha, you talked about sort of the incentivizing side of this, right? The billable codes and the reimbursement rates and all these sort of things, that it's like, at the end of the day, we can build this amazing system, but if our providers aren't going to be compensated for their time to fill out this information, they're, unfortunately, most of them aren't going to fill out this information. And so just so many, um, implementation challenges have kind of come up for me, that it made me step back and just sort of refocus on where we as payers and providers are really finding some of our challenges, versus, I think, where some challenges exist across different, levers within these ecosystems. And I think, federal and state policy, I think, just continues to be something that we've always been navigating, right? I mean, those things have always been challenging. But sort of what we're going to see come out in these next few years around what is funded and what's not funded, and how policies are changing. And I mean, even things like food stamps and SNAP assistance benefits, we're seeing just drastic, reduction in what we already know was incredibly, inefficient, uh, amounts of funding for people that are really in need. And so, what does food insecurity really start to look like over these next couple of years, when we have sort of, I think, these perfect storms happening around inflation and, wage challenges that even working people are having, let alone folks that are disabled, and, just, more of that programmatic side of this work that I've been thinking about, of, um, how do I really leverage those use cases from a healthcare payer side of things to say, this is why this work is so critical, that we're a part of. And so, again, I know that this group understands the value of all of that. So that was kind of my sharing sort of my initial thoughts of what some of the challenges on my side have been. But then I know that the team put together, like Sarah said, sort of use cases and other stuff to kind of feed into how we tell these stories better about the why. So yeah, I think I'll hand it. Am I handing it to Sarah, or yeah, we want to do one more barriers that anybody else is facing that you want to share if you haven't kind of talked about them already?
I love that, Chris, you already elicited two really tangible assists from Chris and Anne already.
Yeah.
It's really exciting. I'd love to know, like, I want to make sure that you have a spot like space to do the just to have people talk about the barriers more. You talked about opportunities and strategies, right? But I don't have we did you cover your barriers slide? You think?
I think for now, because I was going to say, I think it somehow didn't get in here, but that's a me problem. So, yeah. So why don't we move forward and kind of jump into the next conversation, and then if I feel like it's valuable, I of course can bring it up next time.
Okay, I just want to make sure because this was so lovely. The next section is actually kind of just storytelling, which we just kind of want to validate with you all, I think. And Chris, this like in my mind, this feeds up because I'm all about the one pager these days. Chris Hazen, right? I want to be able to tell the story really quickly to people about why you should get involved. I think about like Chris's efforts, right? So we thought we'd do a little why presentation. I don't know if it feels like it's a great follow-up to your thoughtful philosophical conversation, Chris, but we're going to do our best, right? And so maybe because we have this like teamwork makes the dream work approach right now, maybe we can just start think about whether the stories we have right now are a good seed for those kinds of fact sheet one pagers, Chris. Because there's the fact sheet's great for people who can read a fact sheet, but sometimes you need something a little bit more high level for people who are not going to read all the bullets. Okay, so we already talked about why we shifted. We had a whole other agenda for this meeting. Demery can attest. And Chris really called us in because the moment in time is a really unique one. There's still so much more work to do. And so we thought we would just kind of like field test some of the whys that are at the heart of what we do. And then maybe instead of just presenting on it, we can actually workshop it into something that is that fact sheet one pager, Chris, that you mentioned. But I hope you feel the theme like in the next slides. Next slide. So there's a theme in sorry, it's a little busy. There's a theme in each of these slides, okay? The theme is the problem statement on the left, and then the right box are our solutions that we offer. And then the bottom is just an example, Chris Hazen, of all the evidence that is underlying that solution that we developed. And Lauren's AI note taker is here, but socially determined is not here, and they're a super friend in this concept as well. I just want to acknowledge it. So this is actually kind of my gravity origin story, this story, right? I was the head of quality for a small rural hospital. I was the head of my small rural hospital's health service area accountable community for health. I'd been like Chris in the nonprofit social care ecosystem for 15 years before I became a clinical provider. I ran a CDC. I worked at a food bank. I was an organic farmer. And so I was originally, immediately the hospital was like, we put you in charge of herding all the social care cats. And I was like, okay, sounds like a plan. I'm really accustomed to working on housing and gardens. And yeah. So this problem statement, so Chris, we can imagine, Hazen, I can imagine us making like one pagers and fact sheets with this kind of layout, right? You're a small rural hospital trying to improve outcomes on core metrics. You want to be able to analyze how the upstream drivers identified in your community health needs assessment are affecting readmissions, right? You're spending considerable time connecting unhoused patients to Safe housing at discharge to limit hospital stays and prevent readmissions. My COC friend, Chris Durance, you know this, like what this like how challenging this is. And you want to generally direct critical case management resources to those in greatest need. What do? Right? So our social risk ICD codes were built really with this in mind, right? And you're going to see on the next slides like what those are. So they're capable of integrating into risk stratification models. They're already being integrated into national models. Every code that we develop, Johns Hopkins ACG ravenously devours, and like our friends at Socially Determined use in risk sensitive risk algorithms, right? And this is just an example of the evidence is how social risk adjustment and hospital readmissions reduction program is a really great opportunity. Right. And then one of the things that's kind of an interesting, I didn't even realize this was so timely. So Chris, like in 2024, the homelessness, housing instability, and inadequate housing codes were elevated to complication and comorbidity designation in the National Inpatient Prospective Payment Program. So they're being proposed to be sunset for fiscal year 2027, and the comment period is 6/9. So I just want to say, like, friends of you who know, like, how, like, really it's the homelessness one for me. The argument in the policy is that it's not an exacerbation, and so you usually think chronic conditions aren't included in CCs, like chronic COPD is not like COPD exacerbation is. But homelessness really is an exacerbation of housing instability. It is, so that framework, I'm like, I have my comment letter ready, but I just want to make sure that we're all aware of that. So this is like one of those stories that we were telling that we have, again, in the background of our gravity framework. Like, how do we tell stories of risk? How do we support small hospitals who are trying to take care of people and identifying and triaging case management resources? How do we support hospitals in representing the labor and cost of connecting unhoused individuals to services to prevent readmissions? All of those things are back there. Next slide. Oh, and then I forgot to say there's a little call out. We're doing this cool thing in future years of actually developing a risk assessment domain. And then, Chris, this is also going to be relevant for our housing friends, right? So one of the things our community-based organizations raise to us is they rarely assess social risks independently, right? You're using the social risk matrix. If you're a housing entity, you're using the VISTDAT, right? You are not just saying food insecurity. You are literally doing a comprehensive assessment of everything and creating a summary assessment, especially like there's whole community-based organizations like community action agencies in Texas. Every single one needs to do a social risk matrix because you have to triage care to those with the highest score, the highest risk, the highest acuity. So again, in this risk-based perspective, gravity's leaning in future domains, which is long coming. Again, supporting social risk assessment that has to happen in a comprehensive fashion to really triage services and direct resources to those highest in need. Any questions here? Okay. And again, this is not the best follow-up to Chris's philosophical conversation, but then next slide, there's more stories. Chris, Hazen, I think we can whip up any of these into a one-pager. So this is a graphic we haven't seen in a while, but if you go to the next, this is like the YZ code graphic. I decided to include it. Next slide. The cool thing about it is every yellow sun is a gravity code, right? So this is our impact as of 2023 in social risk sensitive ICD-10-CM for US use. And Trish was talking about ICD-11. We'll see when the US adopts that. We shall see. But right now,
Stick with the CM10,
right now we're CM10, right? And these are all the codes that we've built to support the use cases that we just mentioned prior. Next slide. This one's a kicker for me. Again, like Chris, again, I think about stories like this is where we are in 2026. And honestly, when I made this slide this morning, I got emotional. Like I was teary. I was verklempt. I still am. And maybe it's because I'm a former farmer, food insecurity girl at heart, but this one just kills me, right? So this is happening now, right? You're a state Medicaid program who's been utilizing food as medicine interventions for food insecure patients in your state. Given increasing food insecurity rates, cost constraints, you need to narrow the qualifying population, not just to anybody with food insecurity, but those with moderate to severe food insecurity, because you have to justify the intervention, from a cost perspective, right? I just do not have enough resources to feed the world. I have to focus my resources, right? So you need a validated, standardized way to assess a moderate to severe food insecurity for your state population. We created and have the only codes for that, right? The USDA and abbreviated Child and Adult Food Security Scale are the only validated methods for assessing food insecurity severity in the country, right? And the ensuing SNOMED CT codes, mild, moderate, and severe food insecurity, are the only way to do it in an enduring way in conditions. There's no other way. There's no other code. Food insecurity doesn't suffice. It doesn't eradicate the fact that like marginal food insecurity is a severe problem with its own health conditions. But if you are trying to narrow the field, this is what we have, right? And on the next slide, you can see this is the graphic that just killed me. The 6th annual Massachusetts Food Access Report, which Massachusetts may have been the state that I mentioned in the previous slide, right? Food insecurity has risen from 19% in 2019 to 40% in 2025. Over 40% of Massachusetts households experience food insecurity as of the time of this report. Demand outpaces response. Children are going hungry. Severe food insecurity. And so like the why, here we are, the why. The how, like all we have is this way of assessing households with standardized means, the USDA tools that we work with the USDA to encode, and those findings codes, which help differentiate moderate, mild, and severe food insecurity households. This stuff hurts, man. It hurts. All right. How are we doing? We have like 15 minutes. We have let's do one more slide. Let's do the tech one, right? So Corey, this is you. Do you want to do this one?
Yeah, sure.
Go for it.
Yeah, so I mean, this is sort of
It's emotional too, but not quite as emotional as me.
Yeah, this one's more of a cross-cutting sort of, in speaking about technology solutions to support these different narratives. This is a cross-cutting set of gravity solutions that relates to closing the loop on social care referrals. So, the story here is, as a community care hub, actively working on connecting and coordinating services for your region, and you want a standard way to identify real-time capacity for social care entities to receive social care referrals, to decrease administrative drag uh, regarding unsuccessful referrals, and support small community organizations with toggling on and off capacity to provide services, and then document successful referral closure aligned with patient-centered principles. So I think a lot of the stories that Sarah showed, could be overlaid with this kind of a use case. And we also, in our exchange standards, can help, with an information model to exchange that data, as well as to create, ways to analyze that data to understand, if the loop has been closed. And so just on the right here, we've outlined a set of, resources within our guide relative to each of the pieces of this story about checking capacity, initiating the referral, tracking the referral to completion, and then also communicating the social care observations, conditions, and services that were delivered. And at the bottom, again, some of the evidence that supports this piece is included at that link. So that's, I think, about it.
Fantastic. We have I see all kinds of things. Christy, I see all these things in the chat. I wonder if we should, so Chris Hazen, this is an example of, these stories are brief examples of myriads of stories we have that have the problem statement that originated the gravity standard, the evidence behind our approach, right? And the ensuing data standards that are there to support it, right? So I feel like someone tell us where to plug in your fact sheet, in a fact sheet, we'll go blah, right? And this was an hour's labor to create this and many more slides, because the evidence, as those who know us, we're nerds, man. The evidence is all behind everything that we do, right? The public health evidence. And Jonathan's nodding. He's like, nerds, right? So I think, Chris, it might be helpful just to give it back to try to elucidate the things that are going on in the chat there. So if people want to work on it, like maybe we can figure out like what's the call to action, right? So if people want to work on a one pager, maybe we can help that happen. Trish, I'd love to understand what you're saying regarding your shareables. Because if we just go forward two more slides, right? So, oh, just one more slide. Here we are. Or maybe she jumped. Oh no, it was two more. Oh, yes. This is just a slide, same thing, but it was on medically tailored meals. Documenting medically tailored meals, successful food as medicine intervention, reduced cost of care, $6,000 in Connecticut, reduced cost. I mean, these are things we know, right? Again, Chris is saying the evidence is there forever. Everyone knows MTM works, right? And our standards are there to support it. So, yes. And so now we go to the next slide. So this goes back to Chris's statement. So giving abounding evidence of the benefit, decreased cost of care, improved health outcomes, given our standards to support nearly every possible intervention and critical analysis you could have, right? What are the barriers to saying yes? Right. Chris and I nerded out on this Dr. Lauren Taylor keynote from the Siren Annual Conference last year. The Whose Job Is It Anyway? Highly recommend listening to that. But maybe we can close just in like next steps with ideas that people have come up with. Don't you think, Chris? It'd be great to just listen to kind of have people come off the mic and just share.
Yeah.
Yeah. So Trish, what are you talking about? Chris, what are you talking about? I can't read all the notes.
Our shareables are kind of they're more than a one pager. There are several pagers of the value of social work. So kind of like what's the ROI with social work, like palliative care, oncology. But I like the one page format kind of thing with the evidence because we don't have as much of the evidence in there. So Chris really lays it out nicely and formats it. So that's why I would I mean, I have an now example he shared with us. So thank you, Chris. But I think that's important. But one of the things I was going to say is I've been doing a lot more work the last 3 years with social prescribing, which I had not looked at for years since it came to WHO a while ago. And now, out of the UK, they have this very interesting additional role reimbursement scheme that they use for critical people that their jobs are actually paid for through primary care networks as a way of financing. And I think, while I think this is still a long time out in terms of being able to incentivize and create a reimbursement scheme to actual elements of social determinants of health or meaning it, you're going to need social workers, community care workers, other people's in social care to actually provide the necessary assessments and do the link work and so forth. So is it a better first step, if you will, to what you were saying, Chris, to create kind of a similar reimbursement scheme model where we can have these key people who we know will be instrumental in this process in addressing social determinants of health with or on behalf of clients in their communities, making sure that we have that necessary workforce in place as a first step. Like, is that easier at that intermediate step first as we work toward building the code systems through Gravity and so forth, and then incentivizing it or developing how we're going to incentivize it through, let's say, CMS, if it's a Medicare, Medicaid facility, or through private entities. And just something that I was thinking about that as we see, and there's other models. I mean, the ARRS model is most popular, but there's integrated care models and budgets. There's social impact bonds that are going on that are shown to be, like a CVS actually providing that private investment. And then as those goals are met in terms of health and well-being through a community-based organization, the government and NHS is actually reimbursing them. So like that idea is like it's actually working in the UK. So smaller scale, but could it be local? Could it be in Massachusetts related to food insecurity? Could we try this out? I don't know. Those are just some innovative things that I think we need to be looking at, and not trying to, say quickly that won't work because we're such a massive system, but could it work for a particular state, let's say, or
Well, that's what the state waivers and live services models
right,
are like,
essentially is
right?
right,
I
right. We're
mean,
doing a lot of that stuff.
yeah, yeah. I mean, that's what states are doing. That's the Medicaid Massachusetts example is
Mhm.
just saying, okay, we can't feed every single food insecure family anymore. Medicaid's now going to focus services on this. In Massachusetts and Michigan, they're doing it different. In New York, they're doing it different. And in Vermont, they're, yes, but yes and yes. Okay, I'm on for the one pager. You know, you decide I'm here. So anybody wants to write me Gravity Project at 8till7.org, the fact sheet, your wish is my command. So that part is clear. We have 5 more minutes. Jonathan?
So I will just say this in closing, right? So as a sales professional, my one job is objection handling. So if anybody's having a conversation with somebody and wants to build the business case for why people should consider this, I can do it in a very skillful and nuanced way that allows them to actually quantify, right, the cost of not doing it. So the idea is to get them to look at it from the financial standpoint of what does it cost for us to take care of really, really sick people as it relates to value-based care and preventative measures. And so if
Mm,
you can get them to think about it from that standpoint, from a policy development standpoint, and then to implement the tools up front to help them quantify that more qualitatively, then it makes it easier to qualify what it takes to take care of really sick people. And then the conversation becomes really, really simple. If you're treating less sick people, are you saving money, right? And if you're treating less sick people, are you improving clinical outcomes?
mm.
And if you're improving clinical outcomes, aren't you having a better quality of life for your stakeholders in your community? See, it's really hard to say no to that. It's really hard to say no to that. And if you do push back on that, you simply say, tell me more about why that doesn't resonate with you. Help me understand. And then as they start to walk down their own pathway of consideration and their own thinking, and they have to reconsider that and how they're going to turn around to their loved ones and their family members to talk about how they're not going to pay for dispensing quality of care, it becomes personal. And until you make it personal for them and make them uncomfortable and be comfortable with being uncomfortable, they're never going to change because they've never been forced to change. So I say that to say this: if you're having a business conversation with somebody and you're trying to figure out how to frame this in a way that you can make the economics worth without putting a cost of value on life, I'm happy to sit in on that conversation and listen and just ask some open-ended objective questions to see if that doesn't move the perspective on how they're willing to approach those discussions. Because what you really want is more people to come to the table as stakeholders to engage in this in a meaningful way. And then, Sarah, to your point, go back to New York, go back to Massachusetts, come back to California, Indiana, Michigan, Ohio, your individual group of stakeholders, and have this conversation at a macro level that then informs federal policy. So I'm happy to help to do that if I can, when and where I can. All you have to do is reach out and ask.
Thank you, Jonathan. That's kind of the theme of Dr. Taylor's. The pitch is the theme of Dr. Taylor's keynote from the Siren Annual Conference as well. It's pretty, I do recommend listening to it. Um, I think that hour went quickly. Again, once I hear something I'm accountable to, I'm on it. So the fact sheet, Chris Hazen, Trish, Anne, I saw all of you in there. We will get that done. I have no question. Chris Durant, any other final thoughts before we go? So grateful for your pivot today. We needed this, I think. I know. I know we did.
Well, I just wanted to thank everybody for just listening to me, let me talk. So I appreciate it. I'm excited to get to know everybody more. So
Well, we're grateful. So, so grateful for your leadership. And related, I think, kind of to what Trish was mentioning earlier, our next meeting is really about supporting and leveraging the power of community health workers in aligning with their capacity to assess social risks and connect individuals to services and centering lived experience in that work. And so that's in July. In just an hour, I kick off the terminology call, and we're so, so grateful. Yeah, there are multiple one pagers. And if somebody wants to summarize the effort, that's to an email, gravityproject@hl7.org. I would love that. But just count us in. We're here to help.
All right.
Thank
Thanks so much, everybody. We'll see you in July.
Thank you.